Hello. In cardiology, if you stand still, you fall behind. That's never been more true than with acute coronary syndromes. Today, we're cutting through the noise to give you the critical, practice-changing updates from the new 2025 guidelines. This is the Dr. Meek Explainer Series.
So let's get right to it. The new multi-society guidelines for ACS are here, and these are not just suggestions. They represent a significant evolution in our standard of care. The question you have to be asking is, are your current protocols and your personal practice truly up to speed?
And of course, a quick but important disclaimer, this content is for your education. It is not a substitute for your clinical judgment, and you should always consult the full guideline documents when making decisions for patient care.
All the information we're discussing is taken from the following sources.
Okay, to keep this as practical as possible, we're going to follow the patient's journey. We'll kick things off with the biggest take-home messages, then move through initial evaluation, in-hospital medical therapy, reperfusion, and wrap up with the crucial steps for discharge and prevention.
All right, let's start with the absolute must-knows. If you only remember a few things from our time today, these are the ones. These are the updates that will likely change what you do at the bedside.
First, when it comes to DAPT for patients heading to the cath lab, the guidelines now clearly prefer the more potent agents, ticagrelor or prasugrel over clopidogrel. The data just shows better outcomes. Second, lipid management gets more aggressive. High-intensity statins are the standard for everyone, period. And now there's a nod to consider starting ezetimibe at the same time to hit our goals faster. Third, those goals are tighter. If your patient's LDL is still 70 or higher on the max statin they can handle, adding a non-statin is now a firm recommendation. And finally, for our intermediate or high-risk end-stage ACS patients, the debate is over. An early invasive strategy is the recommended path forward.
Okay, with those big picture changes in mind, let's rewind and start where the patient journey begins, with the initial evaluation, often out in the field or in the emergency department.
In the pre-hospital setting, the mantra "time is muscle" is everything. The guidelines double down on a very clear pathway. The clock starts ticking at first medical contact. From that moment, we have just 10 minutes to get a 12-lead ECG and interpret it. If you even suspect a STEMI, that has to trigger an immediate call to the receiving PCI center to activate the cath lab. This isn't optional, it's a system goal.
So, what are we looking for on that critical ECG? The distinction is key. For NSTCS, you're on the hunt for new ST depression, at least 0.5 millimeter, or deep T-wave inversions. For a STEMI, the criteria are very specific. New ST elevation at the J-point in at least 2 contiguous leads. And you have to remember those specific voltage criteria for leads V2 and V3, because they do differ based on age and sex.
Now the patient is in the hospital, we have our working diagnosis, and the focus shifts to medical therapy. Let's dig into the key pharmacotherapy changes, especially around our antiplatelet agents.
As we said, ticagrelor and prasugrel are now front and center. For ticagrelor, the standard load is 180 milligrams, followed by 90 milligrams twice a day. For prasugrel, it's a 60 milligram load, then 10 daily. Now this is really important. Pay close attention to that dose reduction for prasugrel. For patients under 60 kilograms or over 75 years old, you have to drop the dose to 5 milligrams to reduce the risk of bleeding. Clopidogrel remains an option, typically loaded with 300 or 600 milligrams.
A common clinical scenario: what if your patient needs to go for coronary artery bypass grafting? Managing that bleeding risk is paramount. The guidelines give us very clear instructions on hold times. For ticagrelor, because it's reversible, you need to hold it for 3 to 5 days. Clopidogrel, 5 days. And for prasugrel, because it's an irreversible inhibitor, you have to give it a full 7 days to allow for new platelet turnover before surgery.
You're watching the Dr. Meek Explainer Series. We're continuing our breakdown of the 2025 ACS Guidelines.
All right, moving on from antiplatelets, the other huge shift in medical therapy is with lipids. There's a new paradigm here, and it's aggressive. The evidence is overwhelming that when it comes to LDL cholesterol, lower is definitively better, and getting there early really matters.
And here's the single number that you need to have locked in your mind. Less than 70. For any patient after an ACS event, if they are on the highest dose of a statin they can tolerate and their LDL is still 70 or above, the guideline now makes a strong recommendation to add in non-statin therapy. That's a major step up from the previous language.
So our medical management is optimized, but the definitive treatment for ACS, of course, is restoring blood flow to the heart. Let's talk about the updated strategies for reperfusion and catheterization.
Our entire strategy here is dictated by the underlying pathophysiology.
It's crucial to remember that in NT, ST, ACS, we're typically dealing with a partially blocked artery. But in a STEMI, we're facing a complete occlusion, a total shutdown of flow, and that demands a far more urgent response.
For NST-ACS, timing of intervention is all about risk. The highest risk patients, we're talking refractory angina, shock, electrical instability, they need an immediate invasive strategy. That means they go to the cath lab in under 2 hours. For other high-risk patients, and this is defined by things like dynamic ST changes or a GRACE score over 140, an early invasive strategy within 24 hours is now the standard of care.
For STEMI, the goal remains simple and absolute. Open the artery. First medical contact, the device time for primary PCI must be under 90 minutes. That's the gold standard. Now, if PCI isn't available within that time frame, you have to consider fibrinolytics, but only if you anticipate that the delay to getting them to a cath lab will be more than 120 minutes.
So, the acute event has been managed, the patient is stable, but our work is far from done. This next phase, discharge and secondary prevention, is arguably one of the most important for ensuring long-term success.
The new guidelines put a massive emphasis on a structured, thoughtful discharge process. This isn't just about handing someone a stack of prescriptions. It means a meticulous medication reconciliation. It means having a follow-up plan confirmed before the patient walks out the door. It means using teach-back for education. And this is critical. A formal referral to cardiac rehabilitation is now a Class 1 recommendation. It's not just a good idea, it's essential. The guidelines also push us to look beyond the purely clinical and assess those social determinants of health that we know have a huge impact on outcomes.
Thanks for sticking with us here on the Dr. Mech Explainer series as we get to our final thoughts.
So we've covered the big shifts, more potent antiplatelets, much more aggressive lipid targets, and clearer risk-based invasive strategies. The evidence is spoken, and the standard of care has been raised. This really brings us to the single most important question you need to take back to your institution. Are your local ACS protocols truly aligned with these 2025 guidelines?
We're committed to bringing you clear, concise analysis of the guidelines and data that change our practice. To stay current, please be sure to subscribe and hit that notification bell for more from the Dr. MEX Explainer series. Thank you for your time.